Second speaker of the day is Dr. Maltese. He is a consultant diabetologist and endocrinologist in Epsom St Helier University Hospital, UK. So please come on the stage for your presentation.
Ladies and gentlemen, let me say that I'm very excited to be here today. I've been very much impressed by the great hospitality of Pakistani people. And of course, I need to thank the organizing committee to invite me today to give this talk. A special thank you to Dr. Sobia Ali, who has supported me in the preparation of this of my journey to Pakistan, and a special thank you to Tej Rehman, a dear friend and colleague of mine who is not present today, unfortunately, at the conference. So I'm going to talk about probably is a relatively new topic for all of you. It's about the role of the growth hormone IGF-1 signaling pathway in aging. This is going to be the outline of my presentation, a brief introduction on aging of population. Then I will give you an overview on aging and the endocrine system. And then I will move to the core of my presentation, which is around the role of the somatotropic axis in the aging process and the contribution of this axis to the development of age-related diseases. And then I'll tell you which strategies we have available, are currently studied to modulate the somatotropic axis, and so slow down the aging and perhaps prevent some of the age-related disease. Increased lifespan and the aging of the boomer generation are leading to an unprecedented growth of the older population. In 2019, in the world, there were 700 million people aged 65 and above. Eastern and Southeastern Asia was home to the largest world's older population, followed by Europe and North America. And the projection says that in 2025, so in about 25 years, the older population will reach 1.5 million. In Pakistan, we will have a similar trend. You can see how the older population is growing. At present, people aged 60 and above represent about 7%, will reach 8.5% in 2030 and 12.9% in 2050. And you can see also a decline in the younger adults, despite we are in a family-oriented country. So with aging, there are the secretory patterns of the hypothalamic pituitary axis change, and the sensitivity as well of the and hormones. And it is believed that age-related changes in some hormones may affect aging and the onset of some age-related disease. So I'm interested as an endocrinologist, geriatrician in aging, but I believe that many non-geriatricians will become more and more interested in aging. And this was the cover of the Society for Endocrinology magazine, the magazine of a few months ago, and you can say how it says it's time to talk aging. As I said, some terms have been coined. We talk about menopause, we talk about andropause, we talk about adenopause and somatopause. You can see how the testosterone declines with aging, peaks around the age of 30 and then progressively declines. DHEA has a slightly different trend, declines soon after the birth, sharply declines, and then around the age of 6, 7, peaks again, and then declines with aging. And you can see instead for the growth hormone peaks around the age of 30, then declines until the age of 60 and reaches a plateau. You can see that the reduction in testosterone, DHEA, and growth hormone determine similar body changes, increase in body fat mass, which means obesity. And obesity is a risk factor for diabetes and cardiovascular disease. We have a decline in muscular mass, which means sarcopenia. And sarcopenia is well known to be a risk factor for diabetes, disability, and frailty. So probably I'm changing my view on aging. And I believe that aging is probably a disease per se, because age-related changes are pathologies. So there is a growing body evidence that in mice with homozygous mutations in GRH receptor, and some transcriptive factors, PROP1, PIT1, mutations in GH receptors, live longer, up to 40% longer than compared to normal siblings. In humans, obviously, we cannot think about trials exploring the effects of somatostatin analogs or growth hormone antagonists. So we have to refer to those cohorts of patients who are affected by isolated growth hormone deficiency. And we all know about the Cindy and Brazilian cohorts affected by GHRH receptor mutations, homozygote mutations. We know about the Swiss cohort of dwarfism characterized by GH1 homozygote mutation. We know about the KRK Highland cohort, which is affected by a PROP1 gene mutation. And we also know about the Lyron syndrome, which is characterized by a GH receptor mutation. What do we know about longevity and mutations in this cohort? I will tell you about. So we know briefly, I want to remind that an excess of growth hormone is associated with diabetes, hypertension, heart failure, and some cancer, and with negative outcomes, including increased mortality. And treatment of acromegaly, of course, reduces the mortality in these patients. I have already mentioned the changes associated with the growth hormone deficiency. Growth hormone deficiency can be idiopathic, secondary to genetic abnormalities, or related to pituitary disease. With regards to isolated growth hormone deficiency, I want to remind that we have 4 types: type 1A, type 1A, type 1B, 2, and 3. It's an important classification for what I'm going to say. Dwarfism in Sindh, in Pakistan. So this severe dwarfism was described in, I think, in 1994 for the first time, and we know that has occurred in members of a kindred with a high degree of consanguinity. It is caused by a mutation in the GHRH receptor, which results in the inability of the receptor to transmit the signal. They are characterized by severe growth hormone deficiency, height between 117 and 134 centimeters. It is a type 1b isolated growth hormone deficiency. It means that there is still a bit of growth hormone which ensures a proportionate short stature. We don't know much about life expectancy of this cohort. We know that they have offspring, so this mutation does not interfere with the fertility. Much more studied, this other cohort was much more studied. Again, it is a cohort characterized by a homozygous mutation in the GRH receptor, GHRH receptor. It is a cohort from Brazil. Was characterized by reduced concentrations of IGF-1 and other proteins. Again, it is type 1b, so you have a proportionate short stature. They have dull faces and some other features. They are characterized by high tones sensor neural hearing loss. Interestingly, these people have a high LDL cholesterol, they have a high blood pressure in adulthood, and but despite these characteristics, they have a normal life expectancy. Actually, some of them have even been longevous. So, this man here, unfortunately, fell from a horse at the age of 89 and died at the age of 94. This was the sister, died at the age of 104. This lady was a little bit unfortunate, died at the age of 65 because of stroke. So despite this mutation, GHRH associated with increased LDL, high blood pressure, these people may have lived longer. In contrast, in a Swiss cohort characterized by a GH1 gene homozygous mutation, characterized by severe GH deficiency, the authors found a reduced life expectancy compared to unaffected siblings, both for males and females. But this is a type 1A isolated deficiency. There is no growth hormone at all detectable. Another example of longevity, in this case in the cohort from the island of KRK in the Adriatic Sea, 25 dwarfs. The last patient was diagnosed in 1996 and diagnosed in 2004. They are characterized by a PROP1 gene mutation with multiple deficiencies. So you have a growth hormone deficiency, you have also a deficiency in TSH, prolactin, and gonadotrophins. What was interesting was that despite these deficiencies and intermittent use of thyroid replacement, these people can have a long life. I think the oldest was was 88. What about this other cohort, the second largest cohort of growth hormone deficiency? This was a growth hormone actually resistance because they were characterized by GHR deficiency. So these were people from Ecuador, and they presented again severe deficiency of GHR and IGF-1. And very interestingly, these people affected by this deficiency had the lower rates of diabetes and cancer. They died mainly by accidents, convulsive disorders, and non-alcoholic fatty liver disease. you can see this is not a proportionate short stature. It was again, it is a type 1A deficiency, growth hormone deficiency. What's the relationship between growth hormone IGF-1 and acquired hypopituitarism? This was a study from 1990 showing that including 333 patients with hypopituitarism diagnosed between 1956 and 1987. It was a retrospective study showing that hypopituitarism was associated with increased cardiovascular mortality. The main cause of hypopituitarism was pituitary adenoma. This is a more recent study, a prospective study including 1,000 patients conducted in the UK between 1992 and 2000. Again, they found an increased mortality in hypopituitarism. There was no association between growth hormone deficiency and mortality. Independent risk factor for increased mortality were female sex, craniopharyngioma, and gonadotrophin deficiency. The mortality was dictated by cardiovascular mortality mainly. What's the effect of growth hormone in these patients? Was explored by a meta-analysis of study reporting mortality in hypopituitary patients and the potential advantages of growth hormone replacement. A meta-analysis of 6 studies including nearly 19,000 patients. Hypopituitarism again associated with increased mortality. Growth hormone replacement reduced the mortality. We know that the growth hormone replacement is safe, so should be used when appropriate. These were 2 studies conducted involving people who had a growth hormone replacement in childhood for isolated growth hormone deficiency, and they were follow up. Growth hormone deficiency was not associated with increased mortality. Actually, was associated with reduced mortality compared to the general population. What about growth hormone replacement in healthy older people? This was a systematic review of randomized clinical trials which compared growth hormone therapy with no growth hormone therapy, or growth hormone and lifestyle versus just lifestyle intervention. 31 articles. They included 220 participants who received growth hormone in their respective studies. And these were older people. Mean age was 69. They were overweight. And what they found was that overall the fat mass decreased, the lean mass increased, total cholesterol decreased, but not statistically. It was not a statistically significant change. And they concluded the person with growth hormone were more likely to experience soft tissue edema, arthralgia, carpal tunnel syndrome, and gynecomastia. And they were more likely to develop diabetes. So growth hormone replacement in healthy older people, individuals, does not look like a good idea, or a good option. The growth hormone IGF-1 signaling has been studied in this model, in these human models of growth hormone IGF-1 deficiencies, but has been studied also in people who live long. So in non-Nigerian female carriers of genetic polymorphism that attenuate this signaling, there is an unexpected longer survival. And individuals who live 100 or longer, 100 years or longer, are enriched with the functional mutations in the IGF-1 receptor gene, which confer partial IGF-1 resistance. So I will move to the core of my presentation. There are some strategies to modulate the axis. at present we know that we know about the fasting, calorie restriction, and we know about some drugs, metformin and SGLT2 inhibitors. So about dietary restriction. So dietary restriction refers to periods of abstinence from eating, fasting, or calorie restriction. Calorie restriction is defined as a 20-40% reduction in calorie intake, but with an adequate, which is not associated with malnutrition. We know that in many organisms, dietary restrictions are associated with an improved survival, and calorie restrictions confers beneficial effects via the attenuation of the growth hormone IGF-1 and insulin signaling pathway. So we know that in animals, in mice, calorie restriction is associated with an improved survival and lifespan. And 40%, they usually studied 40% calorie restriction in animal models. But we know that a restriction up to 65% can induce an improvement in survival and life expectancy up to 65%. This has been shown also in monkeys just a few years ago. This was a study published about 10 years ago. So what do we know about the calorie restriction in human beings? So the first one was a study conducted during the First World War. Danish people were calorie restricted, but they had an optimal consumption of whole grain cereals, vegetables, and milk. The authors of this study observed a 34% reduction in deaths. The second study, very similar, conducted during the Second World War. The government enforced a 20% calorie restriction for 4 years, and this led to a 30% reduction in mortality in the general population. What happens during fasting, less than 3 days? We have an increased production of growth hormone and a fall in IGF-1, which are mediated by an increase in ghrelin. And these changes confer resistance to growth hormone. Downregulation of the receptor, growth hormone receptor, is another underlying mechanism. This is a very interesting study showing how calorie restriction, this was a randomized clinical trial in young and middle-aged, healthy, non-obese people. In this study, the group subjected to calorie restriction reached a calorie restriction of 11.9%. And this group the group is represented by the red line, showed improved cardiovascular risk factors. I will not go into detail for a matter of time. And we have other evidence from studies that calorie restriction can improve the lipid profile, and can also reduce the cardiovascular disease. In this study, people subject to calorie restriction presented a 40% and carotid artery intima media thickness 40% less compared to a control group. And how does calorie restriction improve health and favor longevity? Through reduction in inflammation, improvement in insulin sensitivity, and improvement in lipid profile and blood pressure. Obviously, there are other underlying molecular mechanisms which ultimately lead to a reduction in oxidative stress and inflammation. And even alternate day fasting and intermittent fasting are associated with improvement in lipid profile and other markers of cardiovascular disease in healthy individuals with no diabetes. Another strategy is to modulate the axis is metformin. We know about metformin. I don't want to spend much on this slide. We know that metformin is associated in people with type 2 diabetes. It's associated with a reduction in cardiovascular mortality, reduction in all-cause mortality. And in animal models, it's been shown to extend the lifespan. Again, I don't want this is a review of a meta-analysis of studies showing that the metformin reduces mortality for cancer in people with type 2 diabetes compared to people with type 2 diabetes managed with insulin and other drugs. Can I have a few minutes more? Yeah. 5 minutes, yeah, 5 minutes. So these are the targets of metformin. To be concise, metformin acts on some important pathways, inflammatory cytokines pathway, insulin and IGF-1. And ultimate result is an increased health span and longevity. This slide depicts the interaction between metformin and dietary restriction in attaining longevity. There is currently a study, a trial involving people without diabetes. This is a randomized trial where the people on metformin are compared to people who are not treated with metformin, and the authors are looking at, scientists are looking at outcome. The main outcome is the age-related morbidity. So just to cut a story short, I have been interested in the last few years in an anti-aging hormone, which is Cloto. And Cloto is an anti-aging hormone. It means that if you delete the gene encoding Cloto in an animal, you get an accelerated aging, and characterized by these features. Cloto is a kidney-derived hormone. It is released in the blood, circulating in the blood. It is interesting that if you give Cloto to the Cloto-deficient mouse, you restore some of the features of aging. So Cloto has been, I studied with my group Cloto, and we have demonstrated that Cloto is reduced in people with type 1 diabetes and microalbuminuria, which is a cardiovascular risk marker. We have shown that it is a predictive marker of renal function decline in people with type 2 diabetes, and we have also shown that exert some anti-aging actions in human smooth muscle cells. So this is how Cloto inhibits IGF-1 and growth hormone pathway, promoting longevity. So what about the SGLT2 inhibitors, which I mentioned as a strategy to slow down aging and prevent the onset of age-related diseases? We know about the SGLT2 inhibitors and their cardiovascular renal protection. Interestingly, in the EMPA-REG study, the use of empagliflozin has led to 4.5 years of additional life expectancy at the age of 45. What we have done recently, we have reviewed some recent emerging evidence on the effect of anti-aging effects of the SGLT2 inhibitors, anti-aging effects exerted on some body organs and arteries. These effects are mediated by an increased ketogenesis, reduction in endothelial dysfunction, increase in nitric oxide availability, and moreover, through an inhibition of the insulin IGF-1 signaling pathway. And we speculate that these effects may be mediated by Cloto. What's the reason behind that? It's because there are a few studies showing that SGLT2 inhibitors increase the levels of GLOD. So they may act on the same pathways, including the growth hormone IGF-1 signaling pathway. Our article was featured on the cover of Trends in Endocrinology and Metabolism. So in the previous figure, we can probably implement SGLT2 inhibitors. So my conclusions, the aging process is associated accompanied by decline in the production of growth hormone IGF-1. Studies in humans and animals reveal a beneficial effect of an attenuated IGF-1 action on some age-related diseases and lifespan. In individuals with pituitary disease associated with growth hormone deficiency, of course, growth hormone replacement is important, decreases mortality and provides other beneficial effects. In healthy individual, replacement of growth hormone is not recommended due to lack of strong evidence. Modulation of the growth hormone IGF-1 signaling pathway through lifestyle factors and some selected drugs appear a very promising perspective. Thank you for your attention.